With that, the formal portion of this event will close with thanks to the panelists and to you, the audience. However, as Zan mentioned, it is our practice. We like to leave this Zoom webinar open for some minutes for those speakers and audience who are available to tarry and chat. So many thanks. Have a great weekend. And now we're in the after party.
Wow, what a great session. We can't thank you enough, Jay, Jerry, and Ralph. I don't know if you're still hearing us, Ralph, but you're at least still. Great. That was just magnificent. And we got the ball rolling. Conceptually, we understand that insulin resistance is an important consideration for identifying people at risk and managing it as an age-related indicator, age-related disease indicator. And we have abundant evidence that Jerry and Jay and Ralph wanted to support it.
So, Zan, we had, a terrific number of questions and we just couldn't get to them.
Yeah.
But
I'm
Ralph,
sorry for that.
Abraham asked a very practical question here. Is IR ready for prime time? He uses different approaches or formulas and gets very different results. So even if so one question is conceptually, do we think that IR is a good number for cardiometabolic wellness? Do we think that it's generalizable to aging as a score metric for aging? But even if that's a good thing, what remains between here and there in order to have a reliable, sensitive, specific test that's enough for us to be, we know blood pressure, we know A1C, we have confidence in them. Is this something that, technical details still need to be worked out over a period of time? So any response to Ralph?
I would ask that Ralph has done all these clamps on all the kinds of people. He showed you them all in the beginning. And hopefully he still has a fasting sample from those subjects before they start. I think that he ought to get together with Michael McPhail at Quest and ask Michael to run the IR test on his various samples and see whether or not it correlates with his measure of insulin resistance, which is the gold standard, the hyperglycemic clamp.
No, it's interesting you should say that, Jay, because when Richard Kahn was the medical director or the research director, we did all of these insulin clamps and we measured the fasting insulin. And the idea behind this is that if we could show him that the insulin level, all done by one radioimmunoassay in our lab, reflected insulin resistance, he would make an argument. He would go to the biochemistry leaders of the world to standardize the insulin assay. And we did all of this on a gazillion million people. And it maybe I can exhume that data. The problem was, even though we showed it, Richard never followed up by standardizing the insulin assay. But just measuring the insulin level or the C-peptide are great measures, but there's a lot of variability in them. And I'm not convinced, as I said, the insulin suppression test is, remember, you give propranolol, epinephrine to kind of wipe out the liver, and then you give a glucose infusion in insulin. And so now you have all of these effects of maybe propranolol and epinephrine that are not blocked. And in addition, you're not looking at insulin sensitivity. You're looking at hyperglycemia-mediated glucose uptake as well as insulin-mediated glucose uptake. So the insulin suppression test would definitely not be the way I would do to justify that the assay worked. So I'm sorry I interrupted Zan, but I think it's important that people understand.
Oh, it's very important.
Ralph, you've been arguing against the insulin suppression test for 40 years and in favor of the clamp. And I fully appreciate, that's why I said the clamp is the gold standard, not the insulin suppression test. But this was done in correlation with the insulin suppression test. We need to do it in correlation with the clamp. And you've got all those samples from all those disease states and everything that could be done to make it, to see whether or not it really does work.
Yeah. Well, it's a great suggestion, Jay, to Ralph, and I hope Ralph will follow through. And sort of going back to Jerry's point about the could be a general concern is that there is variability day to day in insulin resistance, however you measure it. Does there need to be something that is analogous to A1C in integrating insulin resistance over time, sort of analogous to fasting glucose is a measure, but a better measure is A1C to give you an average. It's more robust.
Or a derivative measure like a delta rate of change or something that gets more specific and reliable.
Yeah, what
there are
could you
other-
do to address that concern, Jerry?
So, yeah, no, great questions. And again, we found at least using Ralph's Matsuda index, the extremes, if you're resistant, you typically stay there. If you're sensitive, you typically stay there. Again, unless we've shown with exercise, even a single bout, someone was on the questions, is sufficient to reverse that. So again, you can imagine how variable just that is. The patient, if he's basically, that he or she is running to the doctor's clinic, and you can actually alter. You cause that AMPK activation, GLUT4, and then all of a sudden insulin's a little bit lower, and you say, "Oh, you're sensitive," when most of the time you're not. To me, the most best predictors, my third slide, was ectopic lipid. That doesn't change that quickly, and you measure
How do
ectopic
you measure
lipid, the
that?
IMCL in muscle and or liver, and that is insulin resistance through the mechanisms we described. The problem is that's not a simple blood test. That's a sophisticated measurement. I don't see that happening in the clinic in the near future, but that is your chronic index, because even with exercise, that's not going to change quickly. So I don't have an answer. I can't think of a blood test that's going to give you like the A1C, a good index of sensitivity over the preceding several weeks.
And we talked about this in the planning call, but someone was asking about mitochondrial inefficiency and other measures, other candidates for some kind of metric for aging. Any comments for the remaining folks in the audience here?
Well, if you had a simple measure that's something you can measure in the bloodstream that reflected mitochondrial function, I think that would be actually a good marker. The problem is I'm not aware of such a measure. And I do believe that mitochondrial dysfunction is playing a critical role here. But a simple measure of it, I'm not so sure we have that. Jerry?
Are you working on that, Jerry?
Again, this is why I'm spending a lot of money and time on doing NMR studies. They're very expensive, but that's the only way I know to actually measure activity in vivo. Again, liver, muscle, brain. We're going to get ready to do this in the heart, but it's not a trivial measure. And again, many people do ex vivo measurements of mitochondrial function, and that to me is really assessing capacity of the mitochondria, but not telling you what's happening in situ. And that to me is really what I care most about, is in situ mitochondrial activity. And the only way I know how to do that is with NMR.
Well, could it be a kind of imaging test? You go in and you get an NMR.
As I say, not in the near future. This is, again, there's only a few sites on the planet that can do these sophisticated measurements, and quite expensive. It's not something that a general practitioner is going to want to order on check, NMR measurement of mitochondrial activity.
And
And again, to me, I'm not so sure if I, put on my, physician's cap. I necessarily would want that. To me, I care more about than the implication. It's a predisposing factor. I'd care more about if I could order a test, ectopic fat. That to me is really what as a clinician, that's what I want to fix. Ectopic fat, even in the lean individual. That's what I'd want a marker of. And, mitochondria can be trivial, but to say in most cases, again, especially in younger people who are not have a genetic predisposition, it's this overnutrition. This gets into this. We didn't talk about our South Asian Indians. Again, these are individuals prone to ectopic lipid, liver and muscle, even with a BMI of 24, 25. Again, the good news is a mild white caloric restriction reduces the ectopic lipid, and the diabetes insulin resistance reverses. So again, consistent with this concept. And I don't think it's a mitochondrial defect. There's something else that's leading to this altered distribution of fat inside liver and muscle cells. So we're interested in
Could
understanding.
there be an imaging test for hepatic fat?
There,
I mean, for for
There, I mean,
mean,
there
of course-
currently are, Zan. I mean, people. This is how my hepatology colleagues have taken. We do proton NMR, and you can do DEXA imaging. This is what but they're very expensive tests. Not something I would recommend. They're hundreds of dollars per test. And the hepatologists are doing this in liver, but not necessarily muscle. But it's just too expensive to think about routine.
Well, for routine screening for the public today, but in Long Bio, there are healthy longevity clinics springing up all around the globe and sort of concierge medicine approaches. So if you're talking about some imaging or other tests that are in the 3 zeros, hundreds, even thousands, I suppose that there'll be folks at the tip of the spear, maybe not Brian Johnson, the millionaire who's trying to live forever, but there'll be people, executives and so forth who actually would take those tests and will get some validating or correlating data.
If price is not an object, that to me is your best marker for insulin resistance.
Okay, maybe a regulatory marker.
Regulatory.
Surrogate.
Again, you guys are more of experts on these things than I am. You served on the FDA. Regulatory means when you say regulatory, not something to be. How are you using that word, Zan? Regulatory.
Well, as a primary efficacy endpoint that would serve
Yeah.
to
Well,
support it.
certainly, I see. So to consider whether something, a drug is approved, certainly. I mean, well, it's being used, of course, for. Well, again, we don't have
NASH.
indications for NASH. So again, as you know, the indications for NASH are not just liver fat, it's actually inflammation, more importantly, fibrosis. So right now, there are no regulatory endpoints. In my view, it should be actually. Yeah, I think that's a very good point, Sam, that in my view, we know this threshold gets below 2%, or a threshold in skeletal muscle, and that would be a very good that could be a very good regulatory endpoint. Potentially.
Perfect. Great to hear.
I need to go. It's been
All right.
talking to everyone. Really, always fun getting together with you guys.
Well, you were
Always
terrific.
learn from everyone here. My colleagues, Ralph and Jay.
And I too need to
Yeah,
go.
thank you.
Mentioned, so.
Take care, guys. Yeah.
All right, Jerry.
Sign off.
And
Zan,
Jay.
Thomas, thank you for organizing this. Ralph, Jerry, good to see you. Ciao.
Thanks, everyone.
I'm still here, Zan.
Okay, good. Well, we'll focus on you, Ralph. Yeah.
Yeah.
There's so many questions we did not get to, but go ahead if you had some thoughts, Ralph.
Yeah. Yeah. So I come back to the pioglitazone story, so that basically everything that Jerry said, and I'm of course a big believer. He and I think very similarly. But pioglitazone, it to me is probably the best drug that's out there for getting fat out of the liver. In my opinion, if you go back and look at the data that we published, it's as good, if not better, than the thyroid drug that's out there. It gets fat out of the liver. It markedly, in fact, Jerry Schulman and I, our names are on some of these papers together. It gets fat out of the muscle. And what we've shown more recently, the fat that's around the heart, the epicardial pericardial fat, it markedly decreases the pericardial fat. And now we got preliminary data that it also mobilizes the fat out of the myocardium itself. Using the clamp, it's a great insulin, sensitizer. It has all of the attributes of a drug that's truly an insulin sensitizer. We know from IRIS that it worked in insulin-resistant, normal glucose tolerant individuals and preventing recurrent strokes. So it seems to me that we have an avenue, we have a drug that actually will work. People have misconceptions about the fat weight gain and the fluid retention. Those are big issues, and maybe what Sirius is doing will get around the sort of the stigmata of the fat weight gain and the fluid, and that will be a bypass. So if we had a good measure of insulin resistance, and I actually agree with Jay, if I had someone who's say 35, 40, and their mother died of a stroke and the father of myocardial infarction, you know, got the whatever the genes are accelerating the atherogenesis. To me, I would treat that person with pioglitazone. You'd have to explain to them why you're doing it and that it's not approved for this intervention. But the fact is, you know, if your mom died and your dad died at a very early age, you know, you're probably carrying some of the same genes. It might be worthwhile, you know, focusing on a population that's high risk in doing such a study.
Ralph, Art Santoro was asking, why was PO never developed as a drug for hepatic steatosis? His guess is that it was off patent, but is there?
It
you know,
was actually, there were some studies towards developing it, but I'm sure the lack of IP did put the kibosh on a serious effort.
In the serious drug, which you'll hear more about it turns out that the weight gain is more related to activation of PPAR gamma in the brain, and that stimulates your appetite. So the serious drug, which is unfortunately a thiazolidinedione, I told them they should never mention the word TZD. They should come up with a name for the drug, but not poison people's mind. The other thing that this class of drugs do is it activates the pyruvate transporter, and in doing so, markedly enhances mitochondrial function, and you get all of the insulin sensitizing effect without the appetite stimulating effect. So that may have some promise. And remember, that drug also, they started the NASH NAFLD study, and the data looked very, very good.
Yeah.
So that drug also works, as does pioglitazone, or did rosiglitazone, or did troglitazone, although those other drugs had serious side effects. So maybe this is a way around it. And then, you know, this dapagliflozin that Roger Shih and I are working on, if we just could get the funding, we're ready to do the human study, which would show that a drug that works on the mitochondria, and it would get rid of ectopic fat everywhere. That would be, I think, a good choice that would improve the insulin resistance, improve mitochondrial function, and, you know, who knows? You know, the animal data that Roger has shows that the longevity in the mice is markedly extended. So you know, there is this potential insulin sensitizer out there if we just could give us enough money. And, you know, when you think of these big companies, they spend millions and millions, and they spend billions of dollars. A secretary error hitting the wrong button would produce the $5 million that we need to get through the FDA and start the human study.
Well, we are going to bring Roger on because I am excited about that approach. It's really quite spectacular. And we want to feature him and a couple of other novel approaches that are very promising for targeting healthy longevity.
Yeah.
Zan, just a comment from Alan, our collaborator from HealthSpan Action Coalition. The topic here is not directly on our Thrive Act, the Talas's proposed legislation for a regulatory pathway for HealthSpan products, but certainly a marker, a diagnostic that had to do that measured insulin resistance would be able to take advantage of the proposed tier 1 pathway that would provide an earlier access to market. And for people who are still on the call who are interested, please go to our catalyst.org website for actually our session 1 for this conference in February was on the Thrive Act. So for those who are interested in policy, just direct your attention to that. Sorry, go ahead.
Well, that's right. The Thrive Act is very important for catalyzing development of these products, not just therapeutic interventions, but diagnostics and getting those available to people with what we could call a health span indication. So folks, please do look at the Thrive Act. It's a complicated discussion and a lot of jargon involved, but we hope that conceptually will make sense to anybody who looks at it. And we'd love to get feedback as we perfect the Thrive Act.
And Zan, you mentioned that the Thrive Act covers not only medical medicines, but diagnostics, but it also covers supplements. So Ralph, I'm
Yes.
wondering whether on the topic of insulin resistance, I do see a lot of supplements out there that talk about having, I shouldn't say lot, there are very few supplements that have clinical data. And in a subset of them, there are some that claim, with varying degrees of credence or robustness, that they address insulin sensitivity. Do you have any comments to make about things that people can do today? Because developing new drugs is going to take years. What's out there in terms of supplements?
Quite frankly, I have been through all of this literature, and there really are no, I would say, studies out there that have taken any of these supplements and quantitatively shown that you improve insulin resistance. That there's some animal data with some of the supplements, but the fact is, mice and men have one thing in common: they both start with the letter M. And the metabolic profile in the mouse is very different than the metabolic profile in a human. So simply, the basal rate of hepatic glucose production, and this can be translated to energy expenditure, is 16 milligram per kilogram body weight per minute. In a human, it's 2 milligram per kilogram body weight per minute. So the whole metabolic milieu in the mouse is so tremendously different from humans that even if you were to show a benefit of some of these supplements in mice, without really going to humans, I think you have to be very skeptical. And
Yeah,
they
well,
are,
we are.
yeah.
We definitely are. And yet there are some unicorn examples of where there has been a big investment in doing, for example, an outcome trial. The Cocavia flavanol extract from Mars was the subject of the Cosmos trial, which did show very encouraging reduction in CV events. And they've actually shown the product does reduce blood pressure, does reduce insulin resistance. And so you can make a case for that particular supplement on the basis of a variety of evidence, both clinical and in vitro evidence.
And we're not hawking anything here, but just sharing
No,
information.
that's right.
Amazentis has commercialized urolithin A for mitochondrial biogenesis. There are different ways. I can't remember the name of another supplement that mimics exercise from a hormone-based perspective. But the idea is there may be ways to address mitochondrial dysfunction, insulin resistance, inflammation. Those are all things that are very near and dear to the longevity crowd. People who are looking at ways to extend health span and not have to wait until FDA approval to try to do things. Obviously, that comes with its own set of risks and benefits calculations, but I think people are curious about that.
The flavonoid study that you just referred to, if they have cardiovascular outcome data and they have measurement of insulin resistance, why haven't they gone to the FDA with this?
Well, that's a complicated answer. It is in part the way dietary supplements are set up. You can't make disease claims for a dietary supplement, but you can take a dietary supplement and make it a drug just by doing that kind of study. Now,
Yeah.
that's your question then. Why did Mars make it a drug? And
Mars, the candy company, and the animal food company, and the so forth, but not drug company.
yeah, so we don't speak for Mars. I'm not sure what the answer is to that, but at least they certainly could pursue a drug indication, a
And just
disease
another plug for
prevention
the Thrive
indication.
Act, that if we had it in place today, there is a pathway for them to do that.
Yeah, that's exactly right. So the Thrive Act does, just to emphasize, include both drugs, biologics, medical devices, and dietary supplements. And the important thing when we say medical devices, that also includes lab tests, diagnostics that would be potential clinical measures to manage health span risk, or actually surrogates by which interventions could be approved for increasing health span.
You know, the
Uh,
Mars study, if they have these data, why haven't they made it more available, or at least tried to sort of publicize it more to the scientific?
Ralph, that's one of the ironies. Our current laws forbid them from talking about the results of their study. Zan, you want to elaborate on that?
Yeah, well, forbid may be a strong word, but there is a gray area about crossing over into marketing a disease claim without having an approved uh, new drug application for
They
doing so.
publish articles, but they can't talk to them for the general public, or they determine that it's a matter of policy. Their legal department or someone has advised them not to do that. Just for people listening, Catalyst has done a specific session on the Cosmos trial. I believe it's in the fall, November of 2023 that we did this, so people can look at the articles and the people who ran the study. We had a great panel that talked to the results. Sorry, Ralph, go ahead. Or Zan.
Yeah, I mean, it
They
seems
should
to me that if you publish, I mean, it's past tense now, but you know, if you publish an article saying the Journal of Clinical Investigation or Cell or Metabolism or wherever, that would have gotten the information out to the scientific community.
Yeah.
The
Well,
review, you don't have to make any claims.
to be absolutely clear, they did publish the data, and it was in a less than top tier journal because they technically missed their primary endpoint. By protocol, they made the endpoint, but there was clear lack of adherence in taking the product over the period of time of the trial. So that unfortunately dinged the eyes of journal reviewers, as well as if they had gone to FDA and said, we've got the data. FDA would have said, well, you missed your primary endpoint.
But it's a huge trial, different
Yeah.
segments, but 22,000 or so subjects were studied. So from a natural science perspective, you're looking at it and going, you know, there's something here, there's something physiological happening here.
Yeah, but we extol the virtue of companies like Mars investing in those kind of trials because, as you say, Ralph, we just don't have the evidence for dietary supplements typically. There's no commercial case to do that. It costs too much to get data, so you just sell them on a hope and a prayer.
I
That's
know we
also
have,
the sort of
go
problem
ahead.
with the same study is where do you find who's going to support such a study?
Yeah, well, NEAR has been looking for support and has come close, but it just hasn't happened. And
Yeah.
it would be good to have such a trial done. Some people say there are other therapies that might move the needle more. In fact, NEAR himself says that he's gotten Lilly interested in doing a tame trial, tame-like trial of tirzepatide. And so maybe that will happen. It won't be tame, it will be
Targeting aging with what T,
uh,
Tate
yeah,
trial.
tirzepatide.
Yeah. That's a real double-edged sword because, as I understand, he wants to do the study in people who are elderly, not necessarily
No.
over the hill. And that's where you might get into trouble with these powerful GLP-1s in terms of muscle wasting, because there's very clearly an age, we showed, as I said, 1975, there's an age-related decline in muscle mass, and fat mass goes up. And those are the people where I think the real controversy should be about, should you be using GLP-1 drugs in people in their 70s and 80s, where they may start with a mild sarcopenia, so to speak, that's related to age.
Yeah, well, 2 points there. Number one, and this goes to Jay's point about using it for preventing chronic diseases. What the target population is really young people. We want data in young people that they have very low risk. Their event rates will be very low, and it will take years to see clinical benefits in that population. And as you say, older people start with a major muscle mass deficit. And you might say that that in itself is a contraindication for taking these agents. But muscle mass is important to young people too. And this is why I argue with Jay that I'm not sure I would put my daughters on the GLP-1 agonist for the rest of their lives. Certainly for their currently approved indications, I would. But the big question is, would it be safe and effective to put people on GLP-1 agonists when they're 30 years old and don't have any major risk factors, don't have diabetes,
Yeah.
aren't overweight?
But I would make the argument you're willing to treat people, well, the exercise, let's put that aside for a second, but you're willing to treat people with dietary restriction. And I would argue if you lose weight by dietary restriction, that you would have the same decrease in muscle mass as if I treated you with the GLP-1 receptor
Sure.
agonist.
Yeah. Yeah.
And you can argue, well, is that good for the muscle? But the counter argument is that, hey, look, if you have less fat and total body weight to carry around, I need less muscle. So isn't the decrease in is appropriate? And we actually about
No, absolutely right.
yeah, it's a controversy, and we don't have an
Well,
answer.
you need the data to answer the question. And dietary or caloric restriction is a proven way of increasing not just health span, but extending lifespan in mice.
That's right. Yeah.
Yeah.
It's
So,
unproven.
but it's not
Yeah.
proven in people. And in fact, there are a number of reasons to believe that it won't happen in people, even though it works in smaller mammalians.
Yeah, I think again, all of these studies where you're looking, the smaller the animal, the bigger difference there is in the whole metabolic profile
Yeah,
of the animal.
exactly. Yeah,
So you have to
that's
extrapolating may not.
yeah.
Ralph, can I
So
just ask a question? I know we're getting down on time here, but I've wondered as a layperson, the intersection between mainstream diabetology and endocrinology and cardiometabolic practice of medicine, research and medical practice, and the geroscience or health span extension, healthy longevity crowd. What is your current thinking about the intersection between those two disciplines or fields? Is my question clear?
Yeah, I got it. So I think there's a huge gap, to be honest with you. So first, just between the endocrine sort of metabolic group and the cardiology group, it's only recently we've sort of kind of come together. But I can tell you, even though we have meetings together, the cardiologists are not really thinking metabolically. They're more sort of hemodynamically oriented, less metabolic molecularly oriented. But we're coming closer together. A bigger gap now is between the aging gerontology people and both the cardiology group and the endocrine group. Although, I mean, diabetes, people have said, is advanced aging. You die 10 years earlier. The cardiologists understand as we get older, we're now seeing heart failure go up dramatically and atherosclerotic cardiovascular disease. So despite the clear cut, need for us to interact, we don't really interact. Now in San Antonio, because in large part of Nick Musi, the bar shop, I think, is pretty well integrated with the endocrine, metabolic, and cardiology group. But that's kind of, I would say, a unique situation. And there clearly needs to be a lot more integration of people working together. And as I said, we actually have done a number of aging studies, but only because, as I said, the Barshop Institute is part of UT, University of Texas.
Yeah.
Right.
So we see
Well,
these people.
I could not agree more. We need to be working together, these two different worlds. Currently,
agree.
And
don't
Alan is
really
making the
cross up.
point that it's not just endocrine, but CNS and immunology and so forth. That's the point with geroscience, is that it seems to be an upstream. Aging is the biggest factor for a range of these chronic diseases. And so you want to see some sort of integration between the specialists.
Well, it's our quest to break down these silos. And we try to do that by bringing together in our conferences people from across the scientific world, and indeed even outside that world, ethicists and economists, um, policymakers, and so on. So that is one of our main styles, to break down these barriers and to facilitate creative thinking together, problem solving.
It's
Well,
not
Ralph, we
every,
can't thank you enough
yeah.
for hanging on this late and
No problem.
for
My
changing your
pleasure.
travel reservations. And I hope you'll have a good trip tomorrow.
All right, it was great. It was a great meeting. I think all of the presenters did a great job. You did a great job of all organizing it. So I look forward to the next one, particularly with Roger and Jerry, and because I think that will be equally as exciting.
Yeah. Well, we're with you. And we'll see you in Chicago.
Yes, you will for sure. Okay.
All right.
Thank you,
Bye-bye.
everyone, for staying with us.
Thank you all. We sure
Bye-bye.
appreciate it.
Have a great weekend. Bye-bye.